can regenerate. So I think for every single philosophy of occlusion, the concept of regeneration, just like when we make an onlay to reestablish some wear and tear of the enamel into the joints, this can be something really magnificent. So that's what is Alejandro
Perfect.
is
Let's
going to
move on.
share with.
Let's move on to Dr. Weng Chu. Yu Weng Chu is a good friend of ours.
Yes. So Wen is coming from Singapore. So as we say, people all over the world. Dr. Wen and us, we have many training in common in the areas of neuromuscular dentistry, physiology, and craniocervical spine. And Dr. Chu also is been working a lot in the concepts of linguodontics, as he call it, that has to be with freedom of the fascias and working with phrenology and knowing how the body can be free when we make the proper analysis, and we learn how to integrate this in the normal workflows.
And the importance of vagus nerve
Yes.
for sleeping. And so, yeah, really interesting subject, and he's very well versed at it. Let's talk about Dr. Chira, Dr. Dara Chira.
So Dara also, she's an amazing orthodontics. I met her as well at the Arnett group. What impacted me about Dara is that she treats a huge amount of teenagers, and she has a really comprehensive plan that involves full body workflow, full body therapy. She works really nice with physical therapists, and also they make an amazing team with Jeff McClellan in a part to make appliances, and they always looking in interdisciplinary treatment. So I seen them both working together, and that's why I invite them both. But Dr. Darach has too much experience into orthodontics, and I think she combined it really well with the orthopedic part that is really valuable.
Fantastic, fantastic, excellent. Next one is Dr. Marian Evans.
Yeah, Mariana Evans, I have the opportunity to meet her in Chicago 2 years ago when we were lecturing for Academy of Equilibration Society. And we were lucky to have Dr. Dawson in one of the last lectures to be with us, and also Dr. Okeson for me. And I think for us that we treat physiological dentistry, that was a beautiful opportunity to be able to show the biggest brains in occlusion what technology can be these days. And we were so glad that it was really well taken. So Mariana, what I like about it, she has an amazing data. She's an orthodontics, but also a periodontist. And she's been developing workflows for rapid maxillary expansion that most likely we have the experience, or that's what we learned in dental school, that it just happened in kids. Now, with the deficit that we have in facial growth and developing people, I think this sagittal expansion is really amazing, and you will blow away when you see the amount of space that she can create and how she get to manage all the periodontal tissues and how she proceed with the orthophase. It's
Fantastic.
fascinating. I think applies for everybody.
Let's move on to Cyril.
Cyril
Dr.
Gaillard,
Gaillard.
yeah, he's a good friend for France. We met about 12, 13 years ago in United States taking courses in neuromuscular dentistry. And I get to follow him for many, many years. And something that always attracts me is because he's been on the top representatives of neuromuscular dentistry with a top level aesthetics. Sometimes many of the questions that we have in neuromuscular physiological occlusion is that the aesthetics are poor, unfortunately. And then also sometimes that vertical dimensions are too big. So it's consideration. I think Cyril from the beginning he marked a really good point. And what I'm curious to have him is because now he's combining techniques of neuromuscular dentistry combined with some of the principles of Professor John Coyce. So I'm really look forward to see how he made that merge.
Sounds great. Let's move on. Our next one is our own mentor and good friend, Dr. Peter Farrow.
Yeah, Peter Farrow, I'm who I am because him. I think 19 years ago, I met this guy that was like a crazy for me, and he made me crazy or crazier or worse than him. He take me on over his wings and
I'm
he
not
tell
sure
me
if that's
the
possible, but that's okay.
directions I have to go, and Peter was just amazing. So it's like a father for me. I bring him here because I want he take us about his 40 years of experience doing neuromuscular dentistry. So I think he's an authority, and he get to see how neuromuscular dentistry has different phases. Like everybody put a little bit of here and there, and but still we're doing the same. So
The
Peter
evolution.
and
He's seen the
yeah,
evolution of this field.
yeah, he started when was no training centers with the
Hmm.
first people that started this. So I think we deserve to hear Peter Ferro with the all the evolution of neuromuscular dentistry over the 45 years of
All right,
practice.
buddy. Um, we have gone through one line and we've beaten away through 15 minutes. So let's go a
Oh
little
wow.
bit faster.
Okay.
Okay, so Dr. Gerardo Ruales.
Gerardo Juarez is a good friend from Spain. Has to happen that he's Colombian, but he moved to Barcelona, I think, like 45 years ago, 40 years ago. What I like about him is he has a huge influence in posturology and a lot of neurological connections. You will see how fascinated it is. But in addition, because when we post this, somebody say, you have people all over philosophy, but you don't have nobody for the Slovacek or the Vienna school. And then he told me, he said, I was straight there. So I bring him as a friend and also to give an idea about the philosophy of the Slovacek. Okay.
All right, let's talk about Dr. Gutzman. He's a very, very interesting guy that I'm looking forward to listening to.
Yeah, Dr. Lawrence, I met him also to the Arnet group. He's a guy that saved my life often because he's a scientist and he provide me all articles for scientific data every time that I want to lecture. What I like the most about him is his positive attitude. People with the amount of resources in research as he has, he always is looking for articles that he make it work, that he make us think that he has validation. And he's going to talk a lot about a connection with systemic problems into the temporomandibular joints, and also relation of medications that can affect the temporomandibular joints. That is, I think, part of my weakness. We don't know much about that biological part. So I'm really looking forward to learn from him.
Perfect. Let's go ahead. Let's talk about the youngest member, Lucas.
Lucas is the kid of the group. I think he's 30 something years old for Poland. He invited,
Extremely
he's,
smart.
oh my God, super smart. He has an amazing community that he follow him. He developed amazing educational programs all over the world. What we have in common is we all have a background trained by Professor Mariano Rocavaro, and he managed it beautifully in his office. He has a team of physical therapists working inside, but he follows the occlusal principles of Dr. Coy's. And we have many, many things in common, but also we have a few things that we do different, and that's what we want to learn from him. How is that thinking
With the
process?
focus on the common grants. Let's talk about Dr. Lebert.
Yeah, Emilio is an amazing French guy. I get to meet him because he was taking our courses in the center in Dijon, France. But Emilio has been trained by Dr. Legal, this French prosthodontics for France, that he's been writing books and been doing research in chewing cycles. And he write a book and an article that is called Canine Guides, Reality or Myth. And I think Emilio represents exactly about the philosophy of Dr. Legal to understanding the nociceptive and proprioceptive input in chewing cycles and how the engrams and the chewing cycles need to happen in the human body. So that's what Emilio is going to share with us.
Fantastic. Next one is Dr. Martinez.
Dr.
Domingo.
Domingo Martinez. I think we cannot have a meeting talking about TMJ without invite him. He's a huge personality in the renowned worldwide. He is from Spain as well. And what I like a lot, even that we have many different thinking process, is the manage that he does with the temporomandibular joint, the documentation. I think the first time I saw him was like 5 years ago. We has different controversies over time, but at the end we kind of seen that we have the same mission doing it, and then we end up also in really similar positions. But I really like, I think he's need to be a structural person during the meeting because I respect so much the experience and knowledge that she has about temporomandibular joint.
Fantastic. The next one is another very interesting clinician, Dr. McClendon. That
Yes,
the one that I'm.
Jeff is an amazing guy. Jeff, like many of these beautiful guys I met in Arnett, he's a prosthodontist in Manhattan. He practiced with Dr. Levine. And Jeff is, I call him the lips guy because he honestly always has a consideration, not just the aesthetic of the lips. He's talking about the orbicular disorders, the buccinators, and the attachment with the aponeurosis all the way to bastion, what is called the buccal slim. That is something in the musculature that people doesn't talk much about it besides Rocabaro. But also Jeff follow a philosophy that is called OBI, and he worked with Dr. Dara for many, many years. They developed different appliances. I think it's called Mago. And then honestly, I think Jeff is a great person and a great exponential of this philosophy, and definitely looking forward to learn from him. Plus,
Fantastic.
that is a lot of fun. Yeah.
Tell us a little bit about Valentine.
Okay, Valentine Precop is my partner in our Center of Biofunctional Dynamics Academy in Dijon, France. We have a personal relation. We've been working for 2 years. And the reason that I bring Valentine, because I think is one of the newest person in the working in the philosophy on TM3 specifically TMJ, is because when he called me that he want to work with me, he say, "Hey Javier, I get the same technology and the same equipment that you have, so now we can teach the courses." Has been 2 years since we teach about 5, 6 different courses, and we never get to use technology yet. So the point of view that I want to bring Valentine here is that he tells the story because he is helping now Dr. Baliati, Francesca, with complex cases that she doesn't want to treat. So he is getting enough experience and without technology, because people think that we need the technology that we have to treat patients. And his story demonstrates that even that he has the technology, he's more focusing to be a diagnostician, to be focused to think in
Fantastic.
physiology, and that's what is being successful.
All right, let's move on to Dr. Rick Robley, another very interesting clinician.
Yeah, Rick Antics for Arkansas. And Rick is amazing. I've been following him for quite a bit because he's one of the biggest leaders in clear orthodontics. And he is one of the top notch, and he showed really comprehensive cases doing corticotomies. He has techniques that they make it, and he follow up the cases that I'm seeing from him, increasing airway, and how he reduced the risk and the pressure to the root structures. And it's a really amazing technique. I think we all need to see it because I think patients deserve to have optimizations in the treatments and the time when we have our
Okay,
cases.
next one, I'm going to tell you up front, do not spend 10 minutes on. Dr.
Mariano,
Rocabado. Okay, I know how much you love him. I know we all
yeah,
love him and then we fault him, but let's try to keep it short and stick to the facts.
yeah. So Mariano has been my mentor for 12, 30 years, and we started doing research. He gave me the opportunity to be the dentist for his family. I did research with his wife, and we've been really trying to find new things. The only thing that we do is try to get together and then try to evaluate what we can learn. He's a really mentor to me because he doesn't know that he knows everything. He wants to look for more. He doesn't need more introduction.
Okay, let's make the important thing. Dr. Rocabado is PT, is a physical
Yeah,
therapist
he's a physical therapist, and
that
he
has
has
done
been
over 40 years of research on craniomandibular and craniocervical, um,
correct.
dynamics.
He
Correct?
developed many of the concepts of craniocervical stability and became an authority to evaluate craniocervical dysfunction cases.
Perfect. All right. Next one is Dr. Runkin, Constantine, our good friend.
Dr. Constantine is from Moscow, but he also has a practice in Boston. He is part of the International College of Craniomandibular Orthopedics. That is an organization created by Robert Jankerson, the father of neuromuscular dentistry. And he's going to show you his way of physiological treatment into the patient. But also what I like is he also like a lot of research, and he has a really nice research in patients with cancer and tumors that they have facial maxillary sections, and how they can recover the musculature, harmony, and balance. So that's what I like about Constantine. Really physiologic, great dentist, great leader in Russia. So
Perfect.
great with him.
Fantastic. Next one is Dr. Sutter, Ben Sutter, who I met last year, and I was completely blown away with his lecture. Please tell us.
Yeah, Ben is a good friend, physiological doctor. He's been doing biometrics for many, many years. And he's been working in a concept about the timing of the occlusion of the teeth. So he's a doctor that understands the principles of neuromuscular dentistry and all the philosophies, but he developed a concept of primary care to check the timing of the occlusion, because that can create nociceptive input into the cortex. Now, I'm really excited about the integration between the concept of Ben Sutter with the concept of Francesca and the concept of Milio, because the three of them, they talk about excursive movements and chewing cycles and interference. Dr. Sutter make it with T-scan, and that's what is really good. He created a really good protocol really to do it, utilizing T-scan to equilibrate the timing of the.
Well, that's another goal for our meeting, is to actually build bridges between these guys, because sometimes they work independently and they haven't met each other, and it would be great to create those connections. Now that brings us to the next one. I feel like you've talked so much about Francesca that I already know her and I haven't even met her. So
Yeah, don't ask me to be short in that one, because
oh God.
that is no. I love her, honestly. It was crazy because I need to tell this. I was we both like aesthetics as well, and she was speaking at ceramic symposium for quintessence in Hollywood, and he finished a lecture of cases totally destroyed mouths. And then all that I'm seeing is all these beautiful restorations. And I noticed there was no traditional bite registrations taken into the patient because the mandible wasn't retruded. So as far as she walked out of the room, I go fast behind her and I say, Francesca, you didn't make central relation in these cases. You take this bite differently. This looks like the way I take my cases. Let's go and talk. And that was 5 years ago, 4 years ago. And from there, we created a great relation. She went and took the courses with me in Dijon, so she understands what we talk about. And I think I give you a 10 points because she's spreading worldwide the knowledge of function, making the people comprehends that the human body is more complex, that is physiological, and in everything is all about function. She's amazing in adhesive dentistry, and then I can't wait that you guys get to know her.
Yeah,
I
you
love
forgot
her.
to mention that
Yeah.
she was trained by Pascal, and she's a huge authority on adhesive dentistry.
Yes.
All right, let's move on to the next one, which is another one that I'm really looking forward to, Dr. Valerio. Please do.
Yes. Patricia is the only doctor that I don't have the pleasure to know her personally, and but it has a special connotation for me. Orthopedics has been something really important because in Latin America, for us, we have a stronger basis in orthopedics than in orthodontics. She worked with Dr. Wilma Simoes, who is one of my mentors. My initial intentions was to bring the Professor Simoes to be with us, but she's a little complicated these days. So she say, let me send Patricia. She will represent the beautiful. She's an international speaker. She's been teaching the principles of orthopedics
Beautiful.
all
Yes,
over the
because
world.
a very important point here is that we're talking about occlusion, but when does occlusion begin? And to me, uh, you know, uh, uh, moving fast with children and setting them up for success in the future is extremely important. So that I'm really looking forward to.
Yeah, she's gonna put a concept that is beautiful because in Latin America, kids start being treated at 4 years of age, and in America about 7 or 8. So we're gonna see what is the value to start treating kids
Correct.
in the earliest stage. So it's beautiful.
Fantastic. All right, now comes the next one is the most difficult of the interviewees, only because of the language barrier, but hopefully we can pull it off. Gustavo, tell us about Gustavo.
Yeah, yeah. Gustavo is an amazing guy from Argentina. He doesn't speak English, but it's so valuable the information that he has with us that we're gonna accommodate because we want to steal his mind. Part of what we like about him, he comes from the natological school, uses a traditional prosthodontics, but then he became a patient with cervical issues and neurological problems. And he started going to osteopaths and physical therapists and posturologists. And he started getting to see all these studies that they were doing and how he started getting better. And from that point, he involved concept of posturology. Also, he's a big believer in growth and development. So he treat patients all over, always with the orientation of posturology, but a lot into kids, teenagers, thinking in those important factors about grow and develop of the patient. So it's going to be
Perfect.
fascinating to see him.
All right, we're getting to the bottom of it. Let's talk about Dr. Walker.
Okay, Robert Walker is a chiropractor. I met him about 12 years ago, 10 years ago. He's a chiropractor that he talk about concept that is called craniodontics. He say, and the literature say that the sutures are, the skull is not welded. We have sutures and we kind of flex and move. And part of this breathing happens inside the brain. And all this dynamic motion is reflected into the sutures. Also, when you have a malocclusion, you can have the tendency to create cranial compressions. So he developed protocols to make cranial suture releases. And he knows a lot about posturology, but also he has really good ways to take by registration, thinking in treating joints as joints, muscles as muscles, and a good combination of techniques. I get trained with him and pet Dr. Ferro, and I think it's really important. Just when everything was trying to be simpler, now we know that the skull
It
also
always gets
move
more
and adapt.
complex, right?
It's more complex, yes.
Yes. All right. The last one is our good friend Curtis. Tell us about
Okay,
Curtis.
yeah, Curtis is, my God, I know him from the beginning that I started going to take training in neuromuscular dentistry. He is from Calgary in Canada, amazing dentist, amazing marketing guy. What I like about Curtis is also he developed workflows and techniques utilizing T-scan in combination with transelectrical stimulation. And he developed protocols that combine the utilization of both, but he's doing a lot of studies with NUCA chiropractors. And it's important, what he's going to share with us is how he benefits for interdisciplinary treatment and how he time out the relation with the chiropractors in the normal workflow at his practice.
Fantastic. All right. So we're done with the first part, and some people are asking to speak a little bit louder. So I'm
Okay.
going to try that. The next thing that we wanted to do, so as part of our project, we wanted to create a sort of a framework of standardized questions that, again, we put together with alongside with our feedback with some of our interviewees. And we thought there are some concepts that need to be addressed and questioned and talked about. So we're going to go through our questions. Javier, did you make a slide so we can have that up
No,
for the?
honestly, but I will do it today.
Okay,
We
we
have
will.
actually a few corrections to do, but
Fantastic.
it's okay.
We will
Mhm.
post up the questions so that our viewers can follow with it and see the train of thought. So
Yeah, so technically we try to standardize the questions, and what we're looking for you guys in the audience is that you guys can make notes and kind of start making some tabulations. Ideally, I made this proposal to the Georgia College of Dentistry, with the prosto students that now I'm part of the faculty, and I'm trying to engage the students to help us to make a tabulation of the data that we collect here. So at the end of the day,
Okay.
what we want to see is how these people is treating, what they have in common. The main point is to find what they have in common, because maybe that common denominator is a key of success. So let's try to find out those factors. Let's make tabulations and statistics. And then at the day that we're wrapping this content, we're going to be able to have more information.
That's
So
correct. That's
the
an important. I think that's an important point you just made. That we all have successes and we all have failures, but the important thing is to find out what are they doing right and what are we doing right that we're getting those successful cases, and maybe those common grounds can move us forward and bring the field into some sort of happy grounds. All right,
yeah.
let's talk about the questions.
Okay, we're doing really good in time, Hamid. We have
Well,
30
yeah,
minutes.
it's not
So
easy,
that's
but I
good.
am trying my best.
Yeah,
All right,
this is good. Okay.
all right. So
All right.
let's go with the first question, and please do not mix it with the next one. All
Okay.
right. So, what is occlusion for you, or you know, to
Okay.
you, and who has influenced you? So, as just explain what was that question about?
Yeah, so in this question, it's like us to start to getting an impression about the thinking process of the speaker. Many people can consider that occlusion is just related with teeth, and they can master it. They can talk better than anybody else about contacts and tripodism and how perfect the occlusion pathways and everything has to be done. But can be people that occlusion can combine occlusion and then the joints, and then they're gonna go deeper into that. And I think this is the story of most of the speakers and the guests, is that for them occlusion it combined many things because they have extensive training. And the idea that we put this material together is that you guys maybe can see where they're coming from. So that's the idea of the first question. It's a really wide question, but it's just to get to have the sense to see and more occlusion in the natologic traditional way, or no, I'm more about the contemporary way, just like Francesca, or no, I'm more holistic when I'm thinking about posturology, cervical spine, swallowing, and airway.
All right.
So
Now
that's what we want
you're
to have
going to
this.
the next question. Stop
Oh,
it. All right.
yeah.
So basically, we wanted to know where their influence. So then the second question is, which factors do you consider before the stabilization, prior to stabilization? Such as those you were just mentioning,
Yeah.
posture, sleep.
So many people has been asking me what I mean by stabilization. Stabilization is that point of where you decide to take a bite registration and you expecting some recovering, healing or improving of function. We can have two phases of stabilization. Can be one prior to spleen therapy. That is when we're gonna make in the diagnostic, and then we take the first bite. We clarify the first bite that we take is not the last bite that we take. And then can be when we're gonna move for the restorative phase, can be another stabilization.
Okay,
So in both factors, I think is whatever else they take in consideration. If they interconsult the cases with another physician, or what they consider need to be settled before you move to a next step that we consider stabilization.
all right. And that brings us to the third question, which is what type of information or diagnostic records do you obtain or do you collect?
Yeah,
And
this
why?
is yes, exactly. This is a good point because I think we to all pass through this evolution. I mean, we've been doing this for, I mean, you and I for 18 years at least. And then 18 years ago, we didn't take that many images. We were taking technically some transcranials that was really difficult to see. And I think we evolution to tomograms, and that was a little more clear. But now standard care is about CBCTs. So now has been changing that utilization. In the meantime, we use many other instruments that even in sometimes we don't even use it anymore, like pharyngometers that we're trying to use for the sleep. And then it takes us time to know that the physiology was different. And that's why we start using another resources. So this is, we want to get to know what is the
All right, I think you just
physician
crossed
utilize.
into okay. So the next question is what instruments do you use, and
Oh,
instrumentations to collect those data, such as MRI, jaw tracking,
correct. Okay,
kinetic
yeah.
movement,
But
and showing.
that's what we
You are,
hear.
okay. So
That's what
you,
you hear. That's perfect. Yeah. So here, with the instrumentation, as Hamid say, I posted some videos the other day about dynamic MRIs because I think MRIs can be an amazing tool, but I think it's difficult to have them, and mostly dynamic. So even that, I think in TMJ can be important to have MRIs. I think we don't have access to it, but I think CBCTs are coming standard. It's something that every office has. And also, if you ask me if this is about equipment, I will say not. The thing that you can use is just a cell phone to record videos, and then we will go
sure,
over all
sure.
this.
So it can be anything simple to very sophisticated.
Exactly.
Then the next question is a big one, and I think people should start to see the direction we're moving to. Is do you use an interdisciplinary approach in your treatment?
Yes. Yeah, that is also a common question that we have, that you say how you work the patients with your team. Not all the patients that come to the offices is directly related with pain, but based in the signs that we've seen, many times we find things that patient is not even aware. And in that point, that's like I spoke about the 7 steps of records. That information, the physical therapy can have it, and then they can tell us if that problem is ascending or descending primary. And I think
Okay.
that's what is going to
Yep.
change the conditions, right?
All right.
Yeah.
So the next is that if you have to establish a sequence, if you have to establish a sequence of treatment, what would it be? And to, if we want to get it on a desired vertical dimension.
Yeah, we're talking about this question because,
There's a lot of different
again,
factors.
it's a lot of different factors. Some people that say that many physiological cases they have vertical dimensions that they too big, and technically that can be related because the relation between the car and the garage and the mandible, we always having a conflict. So sometimes we have to take advantage of vertical dimension to catch up the swing back, because this is huge discrepancy between the two structures.
Correct.
But
So we want to know if they're using, if they're considering posture, just aesthetics, airway is very popular today, joint position, and all those things. That's what we're after, to find out what they're considering.
exactly.
So the other thing that we wanted to find out is the facial consideration, facial aesthetics. So when do they actually consider facial aesthetics
Yeah,
treatment? Is
honestly,
it at the beginning?
I even learning myself a lot lately. As we know, I get inspired big time by Christian Koschman's in facial harmony and facial aesthetics and three-dimensional planning. And I think the missing point was to consider facial harmony in the treatments from the beginning. And what I mean with this, when you understand facial harmony, you can determine really well facial asymmetries, or you can see what is not nice into the patient face. Most likely, these factors are related with his development of the face, that he has an intrinsic condition of something that started in a previous stage.
Right.
Also, because when we do restorative cases, it's always important to know what is the position of that incisal edge to determine a vertical dimension, even that's not the vertical dimension that we're going to treat the case. But we technically take two vertical dimensions. One is to make an splint, and that splint need to have a condition because the splint cannot break. So for the splint therapy,
Right.
eventually we need to have some thickness. That's the difference between the
All
both.
right. So let's not get into details of treatments. Number 8. Are you aware of the benefits of the PRGF or IPRF to regenerate bone and tissue structures? As
Yeah, this subject is fascinating to me. I get exposed to this information in details for the first time 2 years ago through the professor Bruno Ardanza from Spain, and I saw him in Spain making a lecture. He has 20 years cases, And he told me, and he said, the same way that you guys put an onlay to restore the wear and tear of that occlusion tables, you guys need to think that the joints need to be regenerated, and that will make a more conservative treatment.
Very
Then,
interesting.
Alejandro Martinez also is a big speaker about the subject. So that's why I invite Alejandro. The difference between the techniques in Alejandro and Dr.
Cardenza.
Ardanza is that one is making only the growing factors, and the other one is making arthrocentesis first. It's cleaning and making a debridation of the adhesion, because we're going to take really advantage of a surgeon that can tell us that they make 500 surgeries, because that is quite a lot.
Beautiful. Beautiful.
And he will say the value why he consider he's seen too many adhesions, and that's why his techniques is combined with arthrocentesis.
Beautiful. Let's go on. Do you notice postural changes after your treatment? This is question number 9. Expected or unexpected, positive or negative? This is really a question for the very astute clinicians that are really watching their patients. Being that we have a group of really great clinicians, we thought this is an important thing to ask.
Yeah, I think that my message in this meeting, it will be that you guys at least collect enough data or enough picture or records about the human body in general. I was talking with Francesca the other day, because she's gonna blow your mind away with these restorative cases that the patient has almost no teeth, and she built up with addition
And no
dentistry,
root canals.
no root canals, no post, just the pure Dr. Manier techniques or bonding, and can just make it beautifully. But then
Beautiful.
I was saying, Francesca, how this patient looks like now. And now she says, I wish I took pictures of posture to see how they changed before. But I think changes, postural changes in what we do big time. And then sometimes I'm seeing changes that I consider that they're not as positive. One of them is most of the time when we bring mandibles forward too much, can be through twin blocks or stretching techniques to take physiologic bites, or by maxillary advancement. The common denominator that I found is a little flattening of the cervical spine. The necks became a little kyphotic. Dr. Racabaro explained that to me, saying about that important connection between the clostridial medial and superior pharyngeal muscles to the hyoid and to the chin. And he explained that it's to measure that they distended, but it's a limit. So to wrap it up into that point is, um, I want, since we have a lot of maxillofacial surgeons here following us for the ANE group, I was proposing them the idea to just to come back and take a look about some of those cases that they make by maxillary advancement. I just check the necks before and after, and maybe this can be a some topic that we can
Perfect.
find more things.
We're on the last 15 minutes.
Okay.
Let's go to question number 10. Um, this is more of a philosophical question, and it's do you consider that at any point the field will be open to a more holistic with a W approach to occlusion, both more organic meaning and both from looking at the whole person and the whole body, meaning
Yeah,
and
I think the everything in life starts with something, with a belief, with a dream and a belief. And the entire why we're doing this symposium is because we want that you guys get the opportunity to see the information for these speakers, because they changed my life and they showed many things in common that has a physiologic thinking process. So I want that for this, my belief is I want to know how much the speakers are willing to participate in this revolution of education, and to try to find out if in some point we're going to have more standardization, and we start fighting about occlusion, and we start creating maybe protocols that they more optimize and more close to the real physiology of the human body, that I think we violated it a lot.
Fantastic. And the last question is something that we felt we need to ask everybody, because it really goes to the fundamentals of our beliefs. And can you do it? It is to the clinicians. Is can you describe the events that happen in the joint? Specifically, we're talking about rotation, translation, and where do they expect that the condyle will end up at the end of their treatment? Do they have a specific position? What type of occlusal scheme they're looking for? And you know, what type of, you know, are they looking for?
Okay, this question is I'm excited about it because I'm personally I've been talking really loud about that it doesn't exist a hinge axis rotation, and I have extensive data that it shows cases with advanced jaw trackers that it shows that the events that happen into the joint have different misinterpretations, and that of course is a strong literature based in research that doesn't necessarily wear cadavers. So the reason that you can see here in my background is because this is a case that I put just last week about the comparison in two patients in natural, normal opening and closings. It's in my Facebook page. It's going in YouTube. And I want that you guys see, first of all, how is a reaction of the head also when the patient is making a mandibular opening, but also how is a totally translation into the condo. So we will talk in this question about osteokinematics and arthrokinematics of the synovial joints. And I'm really expecting to have Dr. Rocavaro and all the other physicians trying to give us a description about these two events that they too controversial, where people has been opening vertical dimensions in articulators because they assuming that we function as a hinge axis, what in my way is something that is not that way, let's say. And then we will
Well,
validate.
again, we want to learn,
Yeah,
and we're open to all trains of thoughts, and but mostly we're interested in science-based and physiologically logical explanations. We're not here to create the controversies, and we want to truly understand, and we want to learn, and we can, if we can pick up some new things and add it to our protocol, we're absolutely open. We're not ashamed of telling everybody that we steal minds and ideas.
exactly. We want just to help us to describe something that it can become a standard in that definition of what happened into the joints, and maybe is mostly a description factor that we have. But this question has three fundamentals, right? I think this is the question, and we put this question at the end. That's why many of the speakers they don't have it, or any of the speakers they have it, because we start receiving people asking, but what is your condylar position? Or do you think the condyle rotate and translate first? Or how is your occlusion? So we break this question in three factors. The first one is we want that help us, the people help us to make a description what events happen into the temporomandibular joint. We need to distinguish between arthrokinematics and osteokinematics, so it's no confusion. So we will go deeper into that. Also, we want that the physicians, they determine by experience when they can describe that they finish the cases in which condyle position can be described. Can you name it where it can be? Because when I was doing a lecture the other day with people that we're supposed to don't have nothing in common with me, at the end we found that we end up in the same position, and we say this is like we fighting and having all these controversies, and then you have your ways to take your bites. I have my ways to take my bites, but look where I'm finished, look where you finish, and we almost the same. So I think this is what is beautiful, to try to describe modalities in the way that we do it, but we're trying to unify the concept.
Right. But at the same time, another thing to keep in perspective for everybody, I want them to keep that in mind. The overwhelming majority of dentistry done out there, maybe more than 90% is done in habitual bite. So all this kind of quarrel about occlusion is among maybe 5 to 6% of dentists, and many of them have a lot of successful cases. And it's time that we put these ideologic things away and look at the facts and look at the science and we have instrumentation today that we can clearly track things. Let's use that and let's find the common grounds. That's our message.
Yeah. And the last point of that question, we're talking about occlusion as teeth getting together. In the prosthodontic concepts, we've always been defined stoppers, stabilizers, and some mechanical factors that when we're doing prosthodontics, we have to take as a consideration. So we're talking about a little bit about that occlusion scheme. We're trying to see where you will put those contacts. You will trying to go for a cause-fossa relationship. You try to look for cost interdental space, or you believe what you will do if you have a case that is edge to edge, what you have a case that has a class 3 tendency that they have conflict into the occlusion, how you create those cursive movements, how you create the freedom in chewing cycles, or what is that dynamic thinking process into that relationship between the teeth, because that's what most people knows about occlusion. And again, with all these questions, I think we're going to have a sense about how people is being consider occlusion, thinking with a different mind.
Fantastic. Well, Javier, we have done it, man. We're at the last 5 minutes of the initial meeting. I don't know if you've seen any of the questions. Do you see posing any questions for us?
Okay, so in the meantime, we're looking for questions, so I'm gonna remind you what is gonna be our next speaker. So today, we're gonna be at 1 p.m. because remember the logistic of this event is we having 8 days of interviews, 3 interviews a day with all these magnificent speakers. Then we're gonna have the day, the 1st of May, 12 hours of continued lectures by these speakers. It's called the Occlusion Marathon. It's a gift that we create because I think my information many times need to be free. We want to encourage you guys to start getting love in occlusion. So that's why we put all these organization together. So Peter Ferro is going to be with us at 1 p.m. And today we're going to have at 6 p.m. Dr. Professor Mariano Rocavaro, 2 amazing physicians talking about physiology, about the function, and about friendship and loves and beliefs. Thank you so much. Do you have something else to say?
No. I just want to thank everybody, and hopefully they'll have enough time to join us again at 1 p.m. to talk with Peter.
All right, guys. Have a wonderful day. Stay safe. Stay home. Stay clear. I know that in these times, people already take a lot of continuing education, and maybe people at this point is trying to create more strategies to see how we're going to start again. And maybe that has created a little anxiety. But remember, the most important part is we have a huge people in the top of all of us, that is God. This is happening for something. We deserve to put a little piece of us because we deserve to make a better world for future generation. It's a commitment in all meanings. So I will see you guys at 1 p.m. Thank you, Hamid. You're an amazing moderator. Thank you for keeping.
I want to mention that during our practice, we never made it under 1 hour, and we did it now.
You did it. That's good. That's awesome. This
all right.
is gonna be really good.
Thank
you, guys. Love you all. Take care. Bye-bye now.